Welcome to the June 2015 webinar from the South Carolina Medical Association. I'm Scott Holtstrand, the PCMH Project Director at the South Carolina Medical Association, and I do want to thank Claudia Cartledge and Jenna Rogers for their assistance in preparing this presentation. This webinar will cover NCQA, also known as the National Committee for Quality Assurance, NCQA's Standard 2 for their patient-centered medical home recognition. The South Carolina Medical Association is providing one-on-one practice consulting assistance to physician practices across the state who want to be recognized by NCQA as a patient-centered medical home. As part of our project, we are not only providing the one-on-one assistance, but we're also providing these webinars to provide overviews of the NCQA standards. We did our first webinar back in April of this year, and in April we did a longer webinar that covered all 6 standards, providing a brief overview of the must-pass elements from those standards, and we also provided some general information about why you would want to become a patient-centered medical home and the reasons to do so. And then in May we did another webinar about PCMH Standard 1, and I encourage you, if you have time, to go back to our website and review those 2 webinars in addition to this one. As always, we do want your feedback. We want to hear from you how you think the effectiveness of these presentations are, and suggestions for improvement. And so if you have any type of comments, questions, or anything else, we would really appreciate your feedback. My email address, which will come up at the last slide of this presentation, is scotth@scmedical.org. And we would love your feedback, and any questions that may be raised from this presentation, we would appreciate those questions as well, and we'll do our best to answer them as quickly as possible. Let's go ahead and jump into PCMH Standard 2. NCQA places emphasis in a number of areas, and each standard has its own emphasis that they believe is important for becoming a recognized patient-centered medical home. And Standard 2, if you look at point number 3, bullet 3 here, is all about team-based care. And it's more than about team-based care. They've actually added a few other elements into this standard. But the must-pass element and the primary focus of Standard 2 is on team-based care. Just a little bit about our program. We have worked very closely with 46 physician practices where we assisted directly in their NCQA submission. This was back in March of this year. We've now received back from NCQA some great results. Each practice has achieved the goal that they set. 33 practices earned level 3 recognition, which is the highest that you can receive. And then 12 practices earned level 2 and 1 earned a level 1 recognition. I apologize for that misspelling. Each practice in these 46 had their own internal goals, and my guess is you'll have your own goals as well. And what we want to do is help you get to whatever level you desire. For the practices that we assisted that did not achieve level 3, we are now working to assist them on the next steps to become level 3 practices. This is a slide from an NCQA presentation, and the intent of their Standard 2 that we're discussing today is for the practice to provide continuity of care using culturally and linguistically appropriate team-based approaches. And we'll see how that comes to fruition over the next few minutes as we discuss the specific standards or the specific elements from Standard 2. So the format of this presentation today is we're going to go through each element. There's 4 elements in Standard 2. And so we're going to go through each element, and as we go through each element, I'm going to discuss briefly what each factor means. And if you look down that left-hand side, numbers 1, 2, 3, and 4 are called factors. So factor 1, 2, 3, and 4. We'll discuss briefly each factor and how NCQA wants you to prove that you are in compliance with those factors. And then, where applicable, we'll show you some real examples that have been submitted and approved by NCQA. These will be examples from the 2011 standards, but they will certainly apply in most cases to the 2014 standards. So that's how we're going to do this. We're going to go over the standard in generalities. We're going to then get into specifics for each factor, discussing what kind of documentation is required, and then we'll show you some examples of that documentation. So standard 2A is all about continuity of care. What NCQA is looking for is when patients come into your practice, number one, have they selected a personal clinician? And then number two, when they visit your practice, are they actually getting to see that personal clinician? And the thought behind this is it's important for patients to see clinicians who actually know them, who know their history, who are able to provide that whole person continuous care over long periods of time. Now, of course, they recognize that sometimes for acute visits or other types of visits, it's appropriate to see another clinician. And you may have a practice that's intentionally set up for patients to see multiple clinicians. But if you want to get credit for these points, you do need to structure your practice in such a way so that patients are encouraged to select a personal clinician that they see on a routine basis. You are not penalized if once you measure your results, you're not 100% on this, but NCQA does want you to be aware, because if it's your goal to have patients being able to see their own personal clinician when they come, and they're only seeing their personal clinician 25% of the time, 1 out of every 4 visits, you may want to make some changes to make sure that your goals for your patients are being achieved. So if you look at Factor 1, Factor 1 is really just about helping patients select a personal clinician, giving them that chance and that choice, and then documenting their selection in the medical records. And what NCQA wants to see from this is that you have a documented process or policy that describes how you assist patients and families in making choices of who their personal clinician should be. And then they want to see a real-life example from your EMR, or if you're in paper records, from your paper records, showing a choice that the patient or patient's family has made. And we'll show you an example of that in just a minute here. Factor 2 is about monitoring the percentage of patient visits with their selected clinician. And you notice that it says or team, so they could pick a practice team as well that has multiple clinicians. Most EMRs now will run this report. We'll show you an example or two of this once we get further into our slides. But this is pretty self-explanatory. NCQA wants you to produce a report that says how many patients' visits did you have, and it's over a 5-day period, at least a 5-day period. How many patient visits did you have, and then out of those patient visits, how many of them actually got to see the clinician or team of their choice. And then number 3 is having a process in place to orient patients to your practice. So this is really just developing a policy, thinking through the question, what would we want our patients to know about our practice when they first join our practice? What would be helpful information for them to know, and then having a process and the ability to communicate that to your patients. And all NCQA wants to see here is your process for doing so. And then for those of you who have a pediatric practice, or even a family medicine practice, NCQA wants you to see how are you transitioning children from pediatric care to adult care. What kind of assistance are you providing to the children, or to the families and children as they transition to adult care? And what NCQA wants to see in terms of documentation for this is an example of a written transition plan for pediatric to adult care. Or if you have a family medicine or adult medicine practice or internal medicine practice that sees children, they just want to see that you are, if you see them as adults, you are still helping them transition to adult care. And so that basically covers standard 2A. If you look down on the boxes on the bottom, in order to get all the points for this particular element, you need to do at least 3 of the 4. So if you did 3 of these, but you didn't do a 4th, you can still get all 3 points for this. If you do 2, you'll get 1.5 points for this category. I think most practices will be able to do 3 out of the 4, unless you, for some reason, have an issue with monitoring the percentage of patient visits, in which case you'd still may be able to do 3 of these if you can do number 4. Let's look at just a few examples of this from practices that have submitted in the past. This is an example of Factor 1 where we're required to document the patient's choice of a clinician. And if you look, this is from a from a physician practice EMR. And if you look at where this arrow is pointing, this is a drop-down box where the practice can choose all the clinicians that work for the practice. When the patient says, I want my usual provider to be Dr. X, they can then select Dr. X from the other providers as the usual provider. And then that way, when the patient returns, they'll know that this is the provider that the patient desires to see, or if the patient calls to schedule an appointment, it'll be right up there on the EMR for the practice to see. This is an example of Factor 2. This is from an EMR that does this report automatically. And if you look at this page, what it shows is a report of the number of visits for a week, and then the number of patients that saw the personal clinician that they had selected as their usual provider. And in this case, it was 918 patients out of 1,081 in this practice saw their personal clinician. So this is the kind of report we'll be providing to NCQA. This next slide is another version of the report. This is one from an NCQA presentation, and likely one that was more manually created. But again, same concept. It's got how many patients seen, how many patients actually saw their personal clinician of choice with the percentage. And that's all that would be needed to produce documentation that you are meeting the factors from Standard 2A. The rest of Standard 2A is more about documented processes. I don't have any examples of that for you today, but that's something that we'll work with you on to create your documented processes. And I just like to say this, anytime you get confused about what your documented process or policy should be, the best way to go about doing it is just going to, and I'll actually back up to show you, going to the factors, and let's just say you want to figure out what is your documented process for Factor 3, which is having a process to orient new patients to the practice. All you do is ask yourself the question, how do we want to orient new patients to our practice, or how do we actually orient new patients to our practice? And whatever your answer is, type that out, and that becomes your documented process. And we can help you pretty it up a little bit, make it look a little more official. But the bottom line is you're really just documenting how you do these things. And so you just ask yourself the question, how do we do them? And then whatever the answer is, that's your documented process. Well, let's talk briefly about Standard 2B. This one is actually one of the easier elements to pass of all NCQA. It looks pretty intimidating at first until you realize what NCQA is looking for in terms of proof. And what they're looking for in terms of proof of this standard, which is really all about, or this element, which is about communicating what a medical home is to patients. They're looking for a process that you use to communicate what your medical home does, and then sampled documents that describe what your medical home does. In most cases, what practices will do is they'll create a one-page brochure, like a tri-fold brochure, that will show all 8 of these factors, that will have information about all 8 of these factors. Let's just go through them briefly. So the brochure would have information about how you're, number 1, responsible for coordinating patient care. Number 2, about how to obtain care from your practice during and after office hours. Number 3, emphasizing the patient's responsibility to provide as much information as they can about the care they receive and their medical history. And then how, number 4, you are providing evidence-based care and self-management assistance to patients and families. Number 5, you'll want to communicate how you address behavioral health issues. And I think this is an interesting statistic. 80% of people with behavioral health disorders go to a primary care practice at least one time a year, and then 50% of people with behavioral health disorders actually receive their care for that disorder at the primary care location. And so you communicating how you address behavioral health needs is very important. And then number 6, you describe how you provide equal access to all patients regardless of their payment source. Number 7 is giving uninsured patients information about obtaining coverage. And then number 8, you give them instructions about how to transfer records to your practice. So all these 8 things are ways that you communicate to patients important information about your practice. In most cases, you'll be using a patient brochure, though you're certainly welcome to use letters to them, web materials. You can actually incorporate this into the previous standard 2A3, where you're helping orient new patients to your practice. But in the end, this is just a way to communicate to patients. We're actually developing a brochure template that you can use for your practice that contains all this information. Of course, some of it will be very specific to your practice, so we can help you with that. And then if for some reason you're not able to do all 8 of these things, or you don't do all 8 but do a lot of them, then you can just skip 1 or 2 of these and still get all the points. If you look down on the bottom of that box, if you do 7 out of the 8 of these things in terms of communicating to patients, you'll get the full credit, 2.5 points for this category. I'm just going to give you a very brief look at a sample template that we're still developing. But this template contains a lot of information that is in factors 1 through 8. And this just shows you, this is not too complicated. It's just a simple way to help patients understand what is a patient-centered medical home, what should they be expecting from you, and then what should they be expected to do as well. And so I'm not going to spend too long on these slides. If you want to take a closer look later, you can get access to this slide deck, or you can pause this presentation and take a closer look. But this is usually one of the easier standards to pass, as long as you're willing to invest in doing a patient brochure, or put this up on your web, or find some other ways to get this information to your patients. Standard 2C is, again, if your EMR is working well and has the capability to provide reports, this is another pretty easy element to pass and get full credit for. This is one, though, where you have to do all 4 of these items, all 4 of these factors in order to get the full credit. And what this is asking you to do is just to really assess the diversity of your population, patient population, the language needs of your patient population, providing interpretation services to meet your language needs, and then providing printed materials to meet your patient needs. And under factor 4 about the printed materials, if you can show that there is no language in your practice that is greater than 5% other than English, then you get to check the NA on factor 4. So if you don't have any other non-English speakers above 5%, you get credit for this just by clicking NA, and you don't have to provide printed materials. Though certainly if you do provide printed materials for folks that are less than 5% of your population, that's fine as well. So what most practices do for this is they run reports out of their EMR to assess, first of all, factor 1, the diversity of their population, which includes racial diversity, ethnic diversity, and then at least one other meaningful characteristic of diversity. That can include things like gender identity, sexual orientation, disability, possibly zip code, other social determinants of health. And so this is just a numerator, denominator, and percentage report. I'll show you a couple examples in just a minute. Same thing for the language needs. This is where you're asking your patients what language is their preferred language. You're entering that into your EMR and structured data, which then enables you to produce reports that show what the language diversity in your patient practice is. And obviously, if you do have a language spoken in your practice that is higher than 5%, other than English, and in most cases in South Carolina, that will be Spanish. If you have Spanish speaking above 5%, then you will, in factor 4, need to provide printed materials in Spanish to your Spanish-speaking patients. And to prove that you're doing that, you just will submit some materials that you use, some examples of materials that you use. And then on the interpretive services, this is just either having your own interpreters in-house that speak more than one language, or having a service available to you. Many of the practices I work with have a language service available should they need to use it, since usually most patients don't have these needs. Just a couple examples of some reports. If you look at the top here, it's an ethnicity report for Hispanic or not Hispanic. And in the middle is a report on race, and then on the bottom is a language report. And these were just run directly out of a practice's EMR. Here's another. This is a race report run from a practice's EMR. And this last one is an ethnicity report run from a practice EMR. Now, I have met with some practices in the past that have not collected this data. And if you look at some of this data, a lot of it's unknown, either because the patient hasn't given it or because they have not asked. And so in some cases, you'll have to go ahead and get started on asking patients for this information. But this is another factor or another element, element C, that's generally speaking not too much of a challenge. The greater challenge in standard 2 is in element D, which is what we're going to talk about now. And element D is the must-pass element for standard 2. So this is one where you've got to get at least a 50% score. And if you look at this element, there are 10 factors. And in order to get a 50% score, you've got to have at least 5 of these factors accomplished, including doing factor 3, which is a critical factor. And we'll discuss that in just a moment. And if you want to get full credit for this, all 4 points, you've got to do all 10 of these factors. So because this is a must-pass element, this is one that you'll really need to focus on. You'll really want to make sure that you do this well. And we typically suggest that you do at least 6 or 7 of the 10 instead of just 5, in case NCQA does not agree with you on 1 or 2 of them. Just have a little bit of buffer. And of course, if you want to do 8 or 9 or 10, that's fine as well. So the first factor is about defining roles for clinical and non-clinical team members. In most cases, this is a job description, but it's a job description that's oriented more towards how their jobs fit within a patient-centered medical home. And so this is not just a raw job description. It's really a job description that includes information about how your nursing staff, how your front office staff, how your referral coordinator, how your physicians, how your management, etc., are fulfilling duties that are related to the patient-centered medical home. And we can certainly assist you with thinking through how to structure those if that's one of the factors that you want to do. And then number 2 is about identifying how you take the team approach to the patient-centered medical home. And what they want to see is, it can be an organizational chart or some other way that shows how you've structured the staff into teams in order to meet team-based care. For example, if you're the kind of practice that has a physician and a CMA and then maybe a referral coordinator all on one team, and then you have maybe 3 of those teams, you would show how those teams work independently, and then how maybe they all report up to a practice administrator or a CEO, and then how a referral coordinator, or how other types of specialist referral coordinator or lab or imaging referral coordinators fit into the mix. And so again, this will be really case by case for each practice, but it's likely you already have teams in place. And so we'll just figure out a way to show NCQA how those teams are structured. Well, I'm going to skip over factor 3 for now because I'm going to save that for last. Number 4 is using standing orders for services. This is pretty self-explanatory. Most practices have standing orders in place. In many cases, they don't have them written down, and so this would require you writing down some samples of your standing orders. NCQA wants to review at least one example of written standing orders to pass this one. And then factors 5 through 7 are all about training your practice with respect to items that are particular to the patient-centered medical home. If you look at factor 5, it's about coordinating care. Factor 6 is about helping patients help themselves, whether it be through self-management or behavior change. And then factor 7 is about population health management. So coordinating care, self-management of care, and then population health management are factors 5 through 7. And what they want you to do, what NCQA wants you to do, is to prove that you're doing this, you've got to provide a description of your training schedule, materials, how staff have been trained. And our program is actually working right now on developing training materials for you that you can use for your practice. And these are great things to do because in many cases, your practice team members won't know what population health is, or they really won't understand the significance of care coordination or how your practice might do it. It can be a great way to train new team members when you're hiring them for just helping them understand what a patient-centered medical home is. And then number 8 is about holding scheduled team meetings to address practice functioning. So they want to see a description of your team meetings, how often you have them. Then they want to see at least one example of minutes from your meeting or an agenda or staff memos that are about the meeting. And I do meet with a lot of physician practices, honestly, that don't have scheduled team meetings. This is something you don't have to do it every day, even every week. I would suggest monthly or quarterly meetings where you just get together as an entire staff to talk about what's going on in the practice and how you can improve the care that you're giving to your patients, along with other items that you would normally discuss. And then number 9 is about involving care team staff in your practice's quality improvement activities. And standard 6, which we'll get to eventually, is all about quality improvement, and it's about looking at numbers that you're measuring yourself on, quality measures or patient experience measures, and then working together to improve on those measures. Well, what NCQA wants you to do, and this is actually very helpful, is to involve your staff in those discussions about how to improve. The more people that are involved in these discussions, the more buy-in you'll get in your quality improvement activities. And also, the more good ideas that you'll get. You'll be surprised at the good ideas that will come out of engaging your staff in your quality improvement activities. And then finally, number 10, and this one's a little bit harder. Most practices aren't doing this. There are some that do this. But again, you can pass this without doing everything. And so that holds true for anything on this list. If there are things on this list that you're just not able to do for whatever reason, other than factor 3, you can skip that factor. And as long as you don't skip more than 3 to 5, you can still pass this element. But number 10 is about involving others, like patients or families or caregivers in your quality improvement activities. This may be something that would be useful to you if you, particularly with respect to the patient experience, if you really want to improve on patient experience, there's no better way to do that than to involve patients in your quality improvement activities. And so this is just something that may be a little bit outside of a normal practice's comfort zone, but it's something at least to consider. It's not something that you got to do, again, every day, every week, every month. This might even be a very once in a while, quarterly or biannual type meeting where you involve patients in your practice quality improvement activities. But as more and more emphasis is being placed on patient survey data, it certainly would not hurt to get some feedback from maybe some of your favorite patients or patients who you feel like would be able to provide the most useful feedback. And then let's talk last about factor 3. Factor 3 is traditionally in all the practices that I've worked with, this is the factor that practices don't like the most or hate the most until they actually do it. And then once they actually implement factor 3, I would say that so far in all cases they've either loved it or they at least see the benefits that come from it and continue to do this even if they wouldn't have to otherwise. Factor 3 is all about the daily huddle. And the daily huddle is a very brief meeting. It can either be at the beginning of the day or at the end of the day where you are preparing for the patients that are coming to see you either that day or the next day. And the great thing about a daily huddle is that it gets the physician and nurse or physician and medical assistant or however you structure your care teams. It's just a brief moment to get the care team on the same page, number one. But number two, what it does is it streamlines your day as the clinical provider. Because during this brief huddle, the provider and the care team is able to discuss, they are able to discuss all the important things that need to happen as the patients are coming through the office that day. For example, let's say a patient's coming in and they last saw a cardiologist since their last visit, but you haven't gotten the report back. Well, you'll be able to note that at the beginning of the day, and you're going to be able to ask your assistants to get that report in before the patient is roomed. Or if a diabetic hasn't had an A1C lately, or a foot exam, or whatever, you're able to identify that patient, go ahead and get the necessary materials or items that you'll need to take the tests that you need, and you'll be able to have those squared away in the room ready for you at the patient visit. Because what happens in a busy day is you get into the room with the patient and you realize that you don't have the report that you need, or you don't have the tests that you need, or you don't have the items that you need to perform certain tests or provide certain immunizations. So what the daily huddle does is very briefly, and again it's a huddle, it's not a meeting, it's a huddle. In most cases this will be a 3 to 7 minute meeting at the beginning of the day. It gets you all lined up so that when you need something it's already there. You're not having to step out in the hall or track down a nurse or track down an assistant to find the things that you need. And so in the end, not only is this improved patient care by making sure you don't miss needed things, but it also improves the streamlining of your practice. You're able to possibly increase volume or at least be able to handle the volume of patients that you have more effectively. But this is just, we've seen really good results from this, and in the past under NCQA this was not required. It is now required, so this is kind of something you're going to have to do regardless. But we hope that this is something that you'll actually find significant benefit from. And so what NCQA wants you to see in order to prove that you're having these daily huddles is that you have a documented process or policy in place that describes how you handled the daily huddles. And then they want to see at least 3 samples of meeting summaries or checklist, appointment notes, chart notes that provide evidence that you actually have had daily huddles. In most cases, what we see practices doing is they print out the patient visit list for the day, and then they use that list to write notes on and jot down things that they need to remember or whatever else they need to jot down on that list. And then what we'll do is we'll scan 3 examples of that and use those 3 examples. You don't have to keep these things for a long time. only keep them as long as they may be useful to you. But we will want to preserve at least 3 of these so that we can show NCQA that you're doing this. I've got a couple examples of this on the next couple slides. The first one is, again, a patient list that was printed out. And then what they would do is they would write some notes about the huddle. If you look at the first one, you can see that there needed to be, one of these visits needed to be changed to a PCMH visit because they realized that the patient had a BMI above 95%, which for this practice was a requirement to get into a PCMH care management category. And then if you look at the bottom one, it's about ADD medication issues and about handling an issue with a patient coming in. So these huddles not only prepare you for clinical things that need to be done, but if there are issues with patients, whether it be behavioral health issues or even just behavioral issues for teens or for young children, or if you have a problem patient that you need to be aware of, or if you have a patient that needs certain language services or needs other type of assistance because of a disability, these are all things that you can have squared away at the beginning of the day so that you're not having to take the time during the day to adjust to those needs. Here's just another example of a printout that a practice did of a patient visit day, and then you can see on the right-hand side that they jotted notes about whether the patient was a PCMH patient or whether there was a lab needed or whether there was immunization, a mammogram, or other type of colorectal cancer screening needed. These are just great ways to jot down things so that your staff can know what you need when you get into the room. And that covers Standard 2. Standard 2 is one of the easier standards overall. There are certainly some challenges associated with it, but I would say compared to the other standards, Standard 2 is certainly one of the more manageable ones to accomplish. And we would love to help you work through any issues that you have as you strive to pass Standard 2. As we've said at the beginning, if you have questions about any of the things that we've discussed today, or if you'd like to meet personally to discuss any of these things, we're more than happy to meet with you or speak with you over the phone or answer your emails. And here's my email address again, scotth@scmedical.org. We welcome your feedback and your comments. Because NCQA emphasizes quality improvement so significantly, we also emphasize that internally. And we want to hear feedback from you about how we can improve these presentations. And if we're missing out on information that you think would be useful, we want to know that so that we can provide the information that you need to make decisions that are helpful to you. And then finally, as this closes out our discussion about Standard 2, there will be another webinar in July, and it will be about Standard 3. So look forward to that, and I encourage you to review Standard 1 webinar and the overall general webinar from April if you haven't viewed those yet. And we look forward to this continued discussion. Thank you very much.